Hi, everyone. My name is Brooke Messer, and I'm here to talk to you tonight about myopia management. This is part of a series. I think it's 5 weeks on different specialties within optometry. And so you'll be visiting with different docs over the next 5 weeks on Wednesday nights. So again, I'm Brooke, and I'm here to talk to you tonight about myopia management. I practice in Edina, Minnesota, which is just outside Minneapolis. It's a small private practice. I have 5 employees and 1 associate doc. We focus on specialty contact lenses, so we get to do all the fun, good stuff like scleral lenses, multifocals. We do orthokeratology. You name it, we've tried it. And we also enjoy doing a lot of contact lens development and research. And I just love my team and my practice, and we have such a great time working with the types of patients that we do and connecting with their families and friends. Personally, I'm married to my husband, Brian. We have 2 kids. I have Nora, who's 3 years old, and I have a 2-month-old boy named Hunter. So I haven't seen a cornea in a while because I've been home with him. So on top of having quarantine brain, I also have a little bit of mom brain going on. So if I struggle to find a word or something like that, you'll have to forgive me. I chose this specialty, specifically contact lenses, because I just love the type of people I get to work with. It's so nice to be able to improve people's vision and improve not only their contact lens wearing experience, but also their quality of life compared to other types of care where you're, trying to keep their disease like macular degeneration, or just hoping you don't have to deliver bad news each year. With contact lenses, you're always, looking to improve, and we always have the option to upgrade their lenses with multifocals or make them more comfortable. I mean, working with custom contacts is really just such an awesome experience. But getting back to the myopia management aspect of it, you'll hear similar comments from others that do myopia management. And I think the top one, especially when you're in private practice, is that it's innovative. It differentiates you from others in your area. So you really, can connect with not only your patient, who is usually young, but you also can connect with their families. And so, mom may bring in their child because they're concerned about their myopia progression. And then all of a sudden you're seeing their other siblings, and then you're seeing mom and dad for their multifocals, or even just their glasses or management of whatever ocular conditions they might have. And sorry, we just had some comments pop up over here, so that distracted me. But so it's really nice to be able to just connect with the entire family, which I think is the coolest part of myopia management. But on top of that, it forces you to stay on top of your research and understanding what's going on in not only orthokeratology, but atropine use and soft multifocals for myopia progression. And hi, everyone. I see some fellow Minnesotans joining the conversation. So thanks, guys. It forces you to stay on top of all the myopia management research. And that, I feel like it keeps me on top of my game, not only in myopia management, but also with pediatrics and even like multifocal technologies with what the labs are doing, because we need to take advantage of all those things with these types of patients. I think it also makes me a better clinician when I have to look at a cornea or look at a topography. I need to be extra critical on how the cornea looks, because we are wearing lenses overnight on a young patient, usually. So I feel like it just elevates my game when it comes to, slit lamp skills, analyzing topography, and things like that. Personally, again, I just love being able to connect with my patients and these families. I also love learning from my lab guys. So I'm always sending off a comment or a question when I email in an order. I'll ask about something on a topography or something on a lens. I'll send a picture of the ortho-k fit, and I'll ask a question about that. And it's just with every fit, I gain something more. And so, I don't ever let a fit go to waste. Try and learn something new every time. Even a -3 myope, that really should be a home run when it comes to ortho-k or even soft multifocals. Don't let that opportunity to connect with your lab guys go to waste and really learn from them. Something else, I've been given a list of topics here, so I'm just going to kind of stream through the topics, but please feel free to add in some comments or questions, and I can answer them as we go. I also have some time at the end to answer some questions as well, but I'll answer questions as they come in too, so feel free to throw those out there. First off, we'll talk about if you're going to start up with if you're going to start up with a myopia management clinic, what do you need to get started? So first off, you need everything you need to do a comprehensive exam. So most of us are set up with all of those things. Make sure you have plenty of fluorescene strips, because we'll be looking at plenty of GP lenses, and also evaluating corneas very carefully for corneal staining. Obviously, be handy with your cobalt blue filter, have a Ratten filter handy. All of your custom lens labs will be able to send you a Ratten filter if you've misplaced the one that was given to you in optometry school, if you're not using very many. We have, plenty of them around the office, probably 2 in every exam room. And the labs will always give them out, and they're often on the tables at optometry meetings and events, freebies to grab. So just make sure you have a couple Ratten filters handy for you. Also, when it comes to orthokeratology, some things that I jotted down specific to that, you'll want to know if there's any compounding pharmacies in your area that you can reach out to so these patients can connect with that. There are some national pharmacies that will mail out atropine to your patients if you happen to decide that's the right approach for your patient. But if there's a local compounding pharmacy, it certainly makes it easier for the patient to call, ask questions, talk about insurance and things like that. So searching your area for a compounding pharmacy is a good step. Also, many people ask me, what lab do you use to do your ortho-k or scleral lenses? And really the right answer there is, who do you already have a relationship with, and who speaks your language? What lab guy talks to you the best and explains things? If they happen to also do ortho-k, that's where you want to go and where you want to start. And then if you run into a hurdle where one lens, maybe can't do what you need, or it's a more basic lens and you need something more custom, the labs will kind of guide you along that way and help you decide what lenses are best for your patient. There are lots of fitting resources out there too. So there's training. Many of the labs have an individual plan to get certified to fit their lenses. So you can search on their website or call the company and talk to them, and they can lead you in that right direction. Because if you get certified with their lenses, with the lab that you're going to work with, then again, you'll be speaking that same language, using the terms that they use to describe certain aspects of the lenses. And they'll walk you through how to order, what materials they use, all those things that maybe if you just call up an order from a lab without going through those trainings, they'll ask you these questions and then you may not know the answer to. So those fitter certifications are certainly helpful to get your feet wet. There's often some images in those trainings to show you what a nice fit looks like, and that type of thing. Again, also just stay up to speed on your research with not only soft multifocals, atropine, and ortho-k, all of those things. One of the things that I see a lot on social media when other docs are talking about managing multifocals, managing myopia is, do I need a topography to do ortho-k? And for the first order, you can probably just take some Ks and use their RX to get you a lens ordered. But for the long haul, I do think that having a topography is, if you want to commit to solid myopia management, you definitely need a topographer in your office. It gives you so much more information than just trying to use what the fit is telling you, because what the fit looks like isn't always what the topography looks like. You can see if there's, not enough, if the treatment hasn't fully developed yet, to where you need to wait, or if the lens is decentering when the patient lays down versus when they're upright in your slit lamp. There's just so many things that you can't see from the lens on eye in your office that happens when the patient is lying down, and when the lens comes off, and how the cornea is actually shaped underneath. And so if you want to commit to myopia management, you definitely have to have a topographer. And thankfully nowadays, even for small practices, there are topographers out there that are affordable and very useful. And they're so nice to be able to have. As I mentioned before, I'm always sending off topographies, especially when I'm working with a very custom ortho-k design to improve the fit for the patient and achieve the outcome that we want. So again, I think topographer over just having keratometry readings, it's essential. Next would be, the next topic we have is how do we market our myopia management in our community and to our patients. Definitely number one for us is word of mouth, patient to patient. We have one neighbor kid come in, and then the next door neighbor kids come in, and so on. That really is the word of mouth is probably our number one. And number two would be within the practice, or maybe those two are about the same. So we're talking to every young myope and their parents about myopia management options, keeping in mind that while orthokeratology is maybe our favorite because we get to really customize that treatment for the patient, it's not always best for the patient and their lifestyle. So we bring up all three options, with orthokeratology being number one, soft multifocals being number two, and then atropine options being number three if contact lenses are just definitely off the table for that patient. But again, so our top two marketing are from within the practice, and word of mouth spread from current patients to their friends and family and neighbors. We do offer a credit to current patients who refer a friend to us. So if they refer somebody in and that new patient then goes forward with one of our programs, we do give the referring family a small credit to their account to use toward their next year's ortho-k fittings or whatever fittings that they're doing. If you can't tell, most of our discussion will be around ortho-k because that's kind of the hot topic now, and more complicated in setting up with practice management and setting your practice fees and training your staff around those things. But I'll certainly try and hit on atropine and soft multifocals too. Another way is I do talk to parents with kids during their exam. I don't necessarily use their visit as a selling tool, but if the conversation lends that way and they say, hey, I have a child who wears glasses and they're also on swim team or something like that, then I'll say, hey, we got these options where they don't have to wear contact lenses at all. They can just wear them when they sleep. And that's another way to build that. Things we're looking at doing in the future are connecting with local schools, maybe stopping in at a PTA meeting or sponsoring a pizza night for a sports team, something like that, to get people aware of ortho-k. And even if they're not ready right now, sometimes it's next year when they come back that now they're ready to go forward with some sort of myopia management. Really, it's all about building awareness, because that seed is going to stay in their mind and think about it. And if they're not ready at their comprehensive exam, maybe they'll come 6 months later or be ready next year. Another marketing piece that we use is with our scleral lens and managing of irregular cornea business, we connect with local LASIK centers, pediatric ophthalmology, things like that. And we do have some, I have a couple local ophthalmologists who will refer kids over if their myopia is progressing. And so it has been a way to bridge the gap between optometry and ophthalmology. I think in general in Minnesota, I'm thankful that we have a pretty good relationship, optometry and ophthalmology, in most areas. And so I'm thankful for that. And but I usually am speaking with like general ophthalmologists who do comprehensive exams in addition to some of the surgeries that they do, because they obviously won't really touch a progressing myope with contact lenses, and that's where we'll get those referrals. I'm getting a lot of hellos in the comments, and I really appreciate all of that. So sorry if I'm looking distracted, because I'm trying to keep up with all your comments here, and just really appreciate all of you being here. I'll just quick look over. Dr. Susan Resnick made a note to thank all our CLMA lab partners that are offering discounts and things like that. As I mentioned, the lab guys are the best, and they are such a wealth of knowledge. in both, custom soft multifocals for our progressing myopes and the ortho-k patients, whether they're adults or children. So you guys are just really, you make my week every week with how you support me in my practice. Next, we'll maybe talk a little bit about building your practice around some pearls and pitfalls that I've experienced, and then I'll answer some questions in the columns there. So first off, when it comes to some tips, I think clinically, on the clinical side, when it comes to orthokeratology, I think patience is key. If the patient keeps getting better week by week, maybe it's not as fast as we'd like, and the patient is maybe a little impatient or getting a little frustrated that they're not seeing as well as they had hoped. If they keep getting better, you just wait, just hang in there. Encourage the patient to just hang in there and wait. I've definitely burned myself with making changes too quickly when it comes to ortho-k lenses. Most kids change pretty quickly, and those corneas just shape up and really provide good vision fairly quickly. But sometimes they don't, and you just need to give yourself more time. So if every week the topography looks a little bit better and the vision gets a little bit better, then you just wait. Just have them keep wearing the lenses. Don't make any changes. Because when I've made changes too soon, now I have lenses that are too tight, or they're causing some corneal staining, lens discomfort, things like that. And now you're backtracking. Do you go back to the first lens, or do you order a third lens? And it just gets really messy. So until you know for sure that you have maxed out what that ortho-k lens can do for the patient, you just wait. I promise you, your labs would much rather give you an extra couple weeks on that warranty than make a lens that's not worthy or not going to make a difference, a positive change for the patient. So if you feel like you're on that track where, hey, I just need a couple more weeks, you call up your lab and say, I need a couple more weeks. I think this lens is right and it's going to get the patient there, but they're not quite there yet. I promise you the labs will work with you on that, because they don't want to waste materials either. So, that, I think in ortho-k, number one, that is the biggest point. I've worked with patients who are -8, -9, -10, and haven't made a single lens change. All we've done is just wait the change out. So I think that's my number one tip when it comes to clinical pearls for ortho-k. When it comes to practice management, pearls and pitfalls, having a program in place is really important. I think it justifies your fees. Because you can, in the program, it outlines, how often you'll see the patient, how often you recommend replacing the lenses, how often you recommend having, or when do you recommend having backup lenses, and then on top of not only the contact lens service, the program should include other advice like spending time outdoors and adequate lighting when you're reading, when the child is reading, healthy diet, things like that. Because it's really it's a holistic approach nowadays if you're looking at the research. So your program should include all of that advice to in your fee schedule there. Bringing up fees, it's difficult when you're first getting started with especially ortho-k. How do you set your fees? If you have a number in mind, if you don't fit any ortho-k right now and you say, hey, I'm going to start fitting orthokeratology, I'm going to select, let's say $100 for my fitting fee, or whatever you think it is. You probably need to double it or even triple it. If you're just getting into ortho-k, you don't really realize at first how much time ortho-k takes. There's a lot of chair time. There's a lot of patient education. There's parent phone calls. There's emails. There's consulting with your labs. So there is a lot of not only chair time, but after chair time, time that's spent on each specific patient. And so when it comes to all specialty lenses, somebody shared a little pearl with me way back when that was, if you're getting tired of that patient coming in, you're probably not charging enough because you're getting to that point where you feel like you're wasting your time. And again, I don't want to make this all about money, but we do have to keep our doors open and take care of our staff. And so you want to make it to a point where you feel adequately compensated through the whole fitting. And you're going to have a minimum of 3 or 4 visits per year. We see our patients for the dispense, a follow-up, and at least a mid-year visit, usually 3 or 4 visits at the beginning to make sure everything's good, and then a mid-year visit. So we're looking at 3 to 5 visits every year for every patient that wears ortho-k lenses. So when you think about your fit fees, that's what you want to price it based on that. And we also have taken a stance in our clinic that we replace lenses more often than not. I used to say, hey, when you have a change, then we'll replace the lenses, and they can wear the lenses for several years before we make a change. But then we got into I ended up getting myself into trouble with some who wore their lenses for many years, and now the lens was warped, and duplicating that lens with the lab wasn't exactly the same as what they were wearing. And then you end up just kind of chasing your tail, because again, do you change the duplicate lens? Do you wash the patient out because now they're warped and their corneas are warped? It's really messy. So we actually make our patients change lenses more often than not. Some practices say every year, some say every 2 years. We're kind of in that same boat. Some say, hey, only when you feel like your eyes have changed will we replace the lenses. But again, we've taken the stance of being proactive on that corneal or lens warpage troubleshooting, and encouraging them to replace the lenses more often. When it comes to some pearls and pitfalls or with soft multifocals, again, just a reminder that the goal is to have the most add possible with functional vision, not necessarily 20/20. So just remind parents that, hey, if they're not seeing 20/20, that's okay. The goal here is to control progression. And you can prove to them that they can still see 20/20 by doing a spectacle refraction with the lenses off. That's really the main pearl with soft multifocals. There are, distance center multifocals are what the majority of the research is on right now. And so if you need a distance center multifocal that maybe a lens off the shelf isn't doing it for you, or you need a toric lens or whatever, the custom labs can do that. So again, just reach out to a custom soft lens lab, or maybe your own specialty lab that you like, does both soft and ortho-k, and so just reach out to them. Lastly, my one pearl with atropine, and then we'll get to some questions, is there is so much research on atropine right now with the different concentrations. You have 0.01, 0.02, 0.05, 0.1, 1% atropine. So much research out there. And, the one challenge that comes around with atropine is you cannot be out-researched by a motivated parent. So you have to stay on top of what is in the data when it comes to atropine, because if you come in and you say, oh, I'm going to do 0.01%, and the parent comes back and says, oh, I've seen that 0.05% is actually yields better results, and then now you're stuck in sort of this weird spot on what are you going to do for the patient. So again, just make sure that you are aware of what the most current data on atropine is, so that you can then provide that research to the parent if they have done their own research, but maybe it's outdated. So just don't get out researched by some parents. I'm going to look over, there's a ton of comments over here, just run through some questions. Jake asked about A scans. In ortho-k, yes, A scans, A scans are becoming more and more common, even in private practice. You don't really see A scans in a lot of private practice, mostly in ophthalmology with, cataract management and things. And I think we've learned that nowadays, even if it doesn't appear to be changing in the contact lens, the eye can still be changing. And so that's where A scans are definitely useful. And I think our major companies are going to be coming out with A scans that are affordable for just private practice, where private optometry, where maybe surgery is not being performed. And A scans are definitely becoming standard of care when it comes to myopia management. Another question was deciding between orthokeratology and soft multifocals. For us at our practice, we love doing the custom lenses, and so ortho-k is number one for us. And we have a lot of word of mouth around ortho-k, so most patients come in requesting that. For a soft lens, I think patients who would transition into soft multifocals for for myopia management would maybe be a current soft lens wearer that doesn't really want to interrupt their current schedule, where they, they're happy with how they're handling lenses and they don't really need to learn anything new. We just swap out their modality from a single vision to a multifocal, and it kind of keeps them on their way. Whereas if it's a new wearer, a child in glasses, we're going to probably take them into ortho-k right away. But we always bring up the other options too. Let me see here. Alan and Susan, let's see, you guys are throwing in a bunch of comments. Susan mentioned recommending a contract for myopia management. That's part of our program. So we have a contract that outlines everything: when they're expected to come in, when we expect them to buy new lenses, when we recommend having backup lenses, how many visits per year, what's included, because there are sometimes that things can get confusing. What if you have the patient come in mid-year for a red eye? Is that included in your contract? Those are things that need to be outlined, and there isn't really a wrong answer. If you have a global fee that covers everything, comprehensive exam, red eyes, contact lenses, backup pair, all the ortho-k fittings, fine. Whatever your contract says, that's what it says. If you want to keep that separately and bill their medical insurance for red eye visits, sometimes it's confusing to the parents because they're like, well, the red eye is caused by the contact lens. We know as practitioners that that's not always the case. They could have scratched themselves or whatever. But you just need to have that outlined where it's like, if I prescribe a medication to protect them from infection, then that's going to your medical. Or follow-ups, these are the follow-ups that are included. Anything else is not. Again, there is no necessarily right or wrong answer. It's just whatever you want in your contract, that's what you need. And we have that outlined as well. We try and keep our contract very simple. So we have it down to one page with some boxes on what's included, what's not included, what's expected in follow-ups. And in the future, outlines both new patient fees and established fees. Actually, because there's so much information around a new patient, we've now separated our contracts. We have established contracts and new patient contracts, explaining all of those things and what's included in each. Ellen mentioned an informed consent, discussing risks. Absolutely, I would agree with that. We have that in our in our initial contract is the risks of overnight contact lens wear. Thankfully, in the exam room, we can kind of calm those concerns from parents on risks of overnight lens wear, and they all read about the one kid who had bilateral acanthamoeba, and they worry about that, rightfully so, about their own child, and we also have a handout that goes along with our initial contract that says their recommended cleaning solution, how they clean their lenses, and then a bunch of do's and don'ts around contact lens wear with tap water, different types of soaps, how to take care of their hands, in handling contact lenses and things like that. Those are helpful tools. We're about up in time. But if there's any other questions, the last question here is, what's your go-to multifocal lens for myopia control? Really, the data is around distance center multifocals. And the goal of it is to get, I think the latest data that I read was closer to 4 diopters of add in the peripheral cornea, or in the peripheral line of sight, peripheral pupil. So when it comes to that, if your patient can tolerate that, usually a custom soft lens is where you're going to go. However, if they can't tolerate that much add, maybe they're an older progressing myope that has, they're in school or in high school where they have more visual demands. Sometimes you need to bump them down into, something where an off the shelf type distance center multifocal lens is usable. But many times the kids that come to us are already, super progressed, and we want to be very aggressive in the amount of add that we're prescribing in their multifocal lenses. So a lot of the times we're headed toward a custom soft lens. Oh, Susan says, no time limit, up to you. Let's see. Is there any other questions over here that we can cover? A doctor expresses concern on long-term corneal integrity. So what do I think about long-term corneal integrity for kids who are in ortho-k? So I've read about this a little bit, and I've actually asked some questions to some of the docs who are big in research. So whenever a paper comes out, especially now being on maternity leave and trying to keep my brain semi-sharp, what I've read about corneal integrity long term is it's based on the fit and a good fit. So we have to remember that ortho-k lenses, they modify the epithelium of the lens and very little effect on the stroma. It's from, there is a little bit of maybe some shape change in the stroma, but based on some data, but really it's the epithelium. And so if we're not penetrating down into those basement membranes and, really affecting that, right now the consensus is that it's safe for integrity. At one point there was some talk about being more risky to treat a child who's over 4 diopters of myopia. That was a big discussion point at GSLS like 3 or 4 years ago. But now that has kind of calmed. And I think as we get better with more oxygen or higher oxygen content lenses, with better treatment zones and just better lenses and technology overall, I'm not concerned about corneal integrity at this point. However, it is important, again, other things that are other pieces of equipment that are coming more accessible to just, private practice optometry when you're not necessarily working alongside an ophthalmologist, is being able to monitor the posterior cornea. So it's helpful to have, at least 1 or 2 scans of the child on their posterior float to make sure that we're not masking some sort of corneal ectasia at some point in their lens wearing life. So I do think that we have the ability to manage the posterior cornea in our practice. So I feel covered on that point. But if you don't, it doesn't hurt to, have just a corneal specialist friend that you trust and say, hey, this is what I'm doing, and I just want to rule out something like keratoconus every few years. So I'm going to send my patients to you just for a topography, or for corneal tomography to evaluate the back of the cornea. So again, integrity in general, I'm not so worried about anymore, but just making sure that we don't miss an ectasia. That would be higher up on my list. Dr. Allen said, can we talk a little bit about the difference between ortho-k and ortho-k for myopia control? So let's say there's an adult who wants ortho-k, we can have as big a treatment zone as we like, especially with the way that our custom labs work now. They're just so amazing. You can make the treatment zone bigger, so you cover more of the pupil. They have less glare, less nighttime halos and things when they're driving, just better vision quality overall for an adult. Where ortho-k for myopia control, we look at the topography a little bit differently because we want to compare where the treatment zone is compared to the size of the pupil. And we want to see some of that power change and treatment change within the pupil range, because we need that peripheral plus to control myopia progression. So an adult can do ortho-k to correct their vision, and we can give them a nice big treatment zone. Where again, with ortho-k for myopia management or myopia control, we want to bring that treatment zone down to make sure that peripheral plus gets in there. Because again, the more peripheral plus we have, the stronger control that we will have over that patient's progression. Alan replied to Dr. Ho there about the epithelium and the contract. Jake's got a good study listed. Let's see here. How do I counsel patients and parents on safe lens wear in the time of COVID? Or if the child had a respiratory infection or fever or something like that. So there's a lot of resources out there from, let me see here. I think it was, somebody may type it up if you see that. I think the AOA put out a graphic, and I think maybe Review of Cornea or somebody else put put a graphic out about safe contact lens wear. It's on my website, Cornea and Contact Lens Institute, and I think it's on some of the other ortho-k Facebook pages. Or excuse me, it's on my practice Facebook page. We posted it about safe lens wear. But again, it goes back to, per the data, there's very little research that supports COVID is transmitted through the ocular surface. And so there's really no data at this point pointing to discontinuing lens wear when you're healthy. So as long as you have good hand hygiene, you're washing your hands before and after when you handle your lenses, and you don't wear your lenses when you have a red eye, or if you're sick, where you'd be coughing in your hands and maybe touching your eyes and your face a lot more. So just, I'm not necessarily trying to stir up anything extra on my patients other than just reinforcing what we've already taught them about good hand hygiene and good lens care. So making sure their lenses are clean, they're not overwearing their lenses, and they're, again, clean hands when they remove and handle their lenses. And then if they are sick, that would be the time to discontinue their wear, which brings up a good point with ortho-k. I don't tell all my patients that they should have, updated glasses, but they should always have every year. They don't need to update their glasses, but what they should have is a pair of glasses that's fairly close to the prescription that we started at, and it needs to fit their face. So if you have a 17-year-old who's been wearing ortho-k for 10 years, they probably won't be able to wear the glasses that they wore when they were in second grade. So they need a backup pair of glasses that's fairly close to their refraction. We don't necessarily wash out our ortho-k patients all that often, but we try and, make the best educated guess on what their refraction was, looking at the changes we've made in the ortho-k lenses over the years, to, sort of estimate what amount of myopia they have if we haven't washed them out. If at some point during the year or during the years of ortho-k wear, we've washed them out, then we'll, obviously go on that. But they should have a wearable pair of glasses for times like this when perhaps they shouldn't be wearing their lenses because they do have an eye infection or fever or something like that. Thoughts on CooperVision MiSight? Yep, it's supposed to roll out sometime mid-year, I think. There's already trainings going on and certifications with the MiSight, so we're super excited about that. I think the main differentiator there is that it's actually has the FDA stamp of approval, and I'm sure that the company will be doing some marketing to the masses, not just necessarily to optometrists, on the benefits of myopia management and that lens. So I think we should anticipate seeing patients come in to our office asking questions about it. And for our young sphere patients who are myopes, how nice to have something with that FDA stamp of approval. With that said, I tell every patient that orthokeratology is FDA approved for myopia correction and not myopia control, and just kind of give them that conversation around that just because it's not FDA approved doesn't mean it's not effective or that it's not worth doing. And so certainly, just because it's not FDA approved doesn't necessarily mean that one thing is better because it is FDA approved, but there are some parents out there who are going to appreciate having that FDA approval. Now that my son said, I'm going to open up my windows a little more. There we go. So let's see, we have lots of questions we have questions on the rest of the workup on accommodative testing, cyclorefraction, axial length. We will do a wet refraction on the initial one when the patient presents to us, and axial length. So we're just getting in my practice. If I had it, we're moving in that direction. But again, we don't have anything that measures an A scan in my practice just yet. However, that's the next big thing on my list. If I have the ability to get that, maybe they were referred over from an ophthalmologist, then I'll get that information from them. Ocular surface evaluation, that's kind of as we go. I'll certainly screen the patient for, sometimes kids will have, outrageous meibomian gland dysfunction. or blepharitis, and we'll certainly talk about that at the first one. And it's kind of just a continued management. Posterior seg evaluation, absolutely. We encourage our patients to have let me rephrase that. All of our patients need to have a comprehensive exam before they start ortho-k. It doesn't necessarily have to be with us because we do get referrals from opticals or retail locations that aren't set up to manage ortho-k patients. And so if they've had a comprehensive exam, we just have those records sent to us. If it's just a word of mouth patient from another patient off the street, then we definitely have a comprehensive exam. So we always get IOP and posterior segment evaluations, definitely. Let's see. It looks like we've covered all the questions. I think we'll maybe wrap up there. This was really fun. Thank you. I was a little bit nervous and talking off the cuff, especially being out of practice for the last 2 months, being at home. But thanks for everybody for those questions. And certainly feel free to private message me if you have any other comments or questions that maybe we didn't cover tonight. And doctors, also thank you to ODs on Facebook, Dr. Glazier and Dr. Resnick. Thanks for asking me to do this. One closing message that I wanted to give was, I'm not in a research institution. I'm not in a big practice where we have all the fanciest equipment. I'm just in a private practice, trying to make it and, develop our program as we go. And so I hope that those of you who are in the same boat as me, where you're thinking, I don't know if I have all the things I need, I hope you got something out of tonight where, you can just take some tools, take some pearls, and get started on your own, and then you build from there. And again, please feel free to reach out to me if you have any questions on that. So, all right, guys. Enjoy the rest of your quarantine. I know we're all looking forward to getting out and back in practice. So best wishes to all of you, staying safe and healthy until we see the end of these isolations and quarantines. Take care, everybody. Bye.